Good evening, everyone. Is my screen visible?
Yes, sir.
Yes, sir.
Okay. So we had a wonderful panel discussion. We'll go ahead with this real-world evidence on osimertinib as standard of care in management of EGFR mutated NSCLC. Thank you, organizers, for this opportunity. So osimertinib was initially developed for second-line therapy in T790M mutated patients of EGFR mutated stage 4 lung cancer patients, and later it was studied in first line in this FLORA, which is a phase 3 RCT comparing osimertinib with erlotinib or geftinib in first line metastatic stage for NSCLC. And as it has already been discussed, there was a significant PFS improvement with osimertinib, which was 18.9 months compared to 10.2 months in the comparator arm. And as we can see, the curves had started from the very beginning. And in all the subgroups, there was a benefit with osimertinib when compared to first-line TKI. However, as already discussed, EGFR exon 19 deletion patients had better HRs when compared to L858R patients. And it also had worked very well in patients with brain metastasis. The very next year, they had also published the OS data, and osimertinib showed a significant improvement in OS of 38.6 months when compared to first-line TKIs, which is 31.8 months, despite a significant crossover. Now, from this data, both the NCCN and ESMO have concluded that osimertinib be considered for referred for first-line therapy in stage 4 EGFR mutated NSCLC. We all know that these RCTs may not represent the real-world population. Only good performance status patients are selected for clinical studies. So we also need to know the real-world evidence. And here we have 3 studies: Flower, Osifact, and Mycona studies, which are real-world studies using osimertinib. To start with, the Flower study is a prospective observational study of first-line osimertinib in stage 4 NSCLC. So it was conducted in around 126 patients, and majority were females, similar to most of the studies, and around 2/3 was non-smokers. And we can see that 30% of patients had brain metastasis when compared to only 19% in the FLORA study. And exon 19 and exon 21 deletions. Exon 19 deletion was in 50% and L858R in around 43% of patients. And around 12% of patients had a PS greater than or equal to 2. These patients are usually excluded in these clinical trials. And here we can see that around 73% of patients had a partial response, 23% had a stable disease, and 4% progressed. So the primary assessment was TTD, which is time to treatment discontinuation. So in studies where we use osimertinib, time to discontinuation seems to be a suitable endpoint rather than PFS, since we tend to use osimertinib beyond progression, especially for oligoprogressive disease, where we locally address the disease followed by continuous osimertinib. So time to disease progression was around 25.3 months in this study. And they had also compared time to discontinuation in patients who were asymptomatic versus those who were symptomatic, and those who had less than 3 metastatic sites versus those who had more than 3 metastatic sites. And as you can see from curves C and D, the median time to discontinuation was not reached in asymptomatic patients, whereas it was 18.8 months in patients who had symptoms. Similarly, it was not reached in patients with less than 3 metastatic sites, and it was around 21.4 months in patients who had more than 3 metastatic sites. They also published the PFS data, and median PFS was 18.9 months, similar to that seen in FLORA. And also PFS was better in patients with no brain metastasis and patients who were asymptomatic at presentation. They also published data regarding time to biopsy, time to pathologic report from biopsy, which was around 7 days median time, and similar to seen in our practice. And median time from pathology report to EGFR mutation status was 8 days, and median time to start osimertinib was approximately 17 days. Around 44 patients had progressed in those 126 patients, and among these 44, 21 patients underwent a rebiopsy, of which 2/3 had a tissue biopsy and 1/3 were a liquid biopsy. Molecular analysis was performed in 13 samples, and what they found was four patients had a MET amplification, one patient had a MET amplification and EGFR amplification, one patient had EGFR amplification, and one patient had HER2 amplification. So all these are targetable resistance mechanisms for EGFR mutation, and we have to check for this, but unfortunately we usually don't do it. Coming to safety, majority of side effects were diarrhea, rash, dry skin, and paronychia, similar to what we usually see. But what was noticed in this study was around 9.5% of patients had venous thromboembolism. 7.9% had grade 3, grade 4 venous thromboembolism. And also ILD or pneumonitis was seen in 9.5% of patients, with approximately 2.4% having grade 3 or grade 4 pneumonitis. And this in venous thromboembolism, there was no difference in rates when compared according to age, performance status, or comorbidity, which indicates that probably this VTE could be related to drug. However, this adverse event wasn't reported in FLORA study. The efficacy was similar to FLORA, but there was an extra adverse event which was seen in this study. Moving on to next study, it is OSIFACT study. It's a retrospective observational study from Japan, and this study had huge number of patients, around 538 patients, with age distribution and gender distribution, smoking status similar to that of what was seen in FLORA. Around 50% of patients had exon 19 deletion and 45% L858R. And they also stratified patients according to PDL1 status. And around 12% of patients had a PDL1 greater than 50%, 31% with 1 to 49% PDL1 TPS, and less than 1% having 30% of patients had less than 1% PDL1 TPS. The median PFS in this study was 20.5 months. And when multivariate analysis was done, patients who had malignant effusions or liver metastasis or brain metastasis had a lesser PFS. Similarly, they had seen that in patients who had a PDL1 TPS of greater than 50%, they had a HR of 2.24. That is, PFS was less than half of what was seen in patients with less than 1% PDL1 status. And as the PDL1 status increased, the PFS had decreased. This was not studied in FLORA, and though it's a retrospective study, it needs proper validation. We need to find out whether really PDL1 status affects efficacy of osimertinib. Coming to adverse events and treatment discontinuation, around 44.3% of patients discontinued due to disease progression, and 25.6% of patients had discontinued due to pneumonitis. So pneumonitis was significantly seen in this Japanese population, and remaining 16% of patients had other adverse events like anorexia, skin disorders, QT prolongation, fatigue, anemia, and all. However, the point to note here is the high incidence of pneumonitis in Japanese patients. So to conclude, the overall response rate was 76.2% and disease control rate of 94.1%. PFS was better with osimertinib, similar to that seen in FLORA, though it was irrespective of PDL1 status, but PDL1 status did affect the HRs for PFS. Median time to treatment failure was 19.1 months, and the discontinuation rate due to adverse events was 18.8%, and especially pneumonitis was high in this series, and it requires further investigation. Coming to the last study, Mykonos study, it's a prospective real-world study of EGFR mutated locally advanced or metastatic NSCLC. It was a global observational study conducted in US, Europe, and Asia. However, this data is from US Flatron Health electronic health records from around 280 US clinics, and inclusion criteria included more than 18 years of age, stage 3B or 4 NSCLC with EGFR mutations. And data was collected through Jan 2020, and study is still ongoing. It was a sub-analysis from US population. And the outcomes were TT and TD, which stands for time to next treatment or death, and TTD, which stands for time to treatment discontinuation, as we had already seen for other studies. So among 548 patients who were started on first-line osimertinib, around 58%, that is 318 patients, remained or were lost to follow-up when this study was analyzed. And 18.8% of patients had received second-line treatment, which included PD-1, PD-L1 combo or monotherapy, or EGFR TKI monotherapy or combination, or a platinum-based chemotherapy. Around 18.4% patients had died while on first-line therapy, and 4.7% discontinued first-line therapy.
My apologies, sir. You are just left with 1 minute to conclude your presentation.
Okay. Yeah. So at a median follow-up of 9.6 months, median time to next treatment or death was 17.9 months. And factors which affected this outcome were stage at initial diagnosis. Smokers had a poorer PFS, and patients with poor performance status and patients with L858R mutation or more than 4 metastatic sites had a lesser time to next treatment when compared to the other patients. Similarly, time to next treatment discontinuation was 17.2 months, and factors like comorbidity status, performance status, EGFR mutation type, and number of metastatic sites had impacted on outcome. So to conclude, the study provides real-world insight into use of first-line osimertinib in advanced NSCLC patients, and the data showed that outcomes were similar to that seen in FLORA. So all these trials had matched the efficacy of osimertinib FLORA. However, the adverse events were slightly more, with 2 events to be notified were venous thromboembolism as well as ILD or pneumonitis, which need to be observed, and the caution has to be taken. However, with a handful of patients which I have treated, I haven't faced any of these problems. So I conclude here. Thank you. Thank you once again, organizers and AstraZeneca, for this.
Thank you so much. Thank you for the wonderful talk, sir. And the upcoming session is